Three, two, one, zero.
Welcome to the Heart of Innovation, 60 minutes that could save life and limb, with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by patient advocacy group thewaytomyheart.org in partnership with Abbott. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of The Way to My Heart, Kym McNicholas, and interventional cardiologist and founder of the Save My Piggies Health Education Series, Dr. John Phillips.
Hello, 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 everyone. You know, some doctors tell patients your vessels are just too small to treat. But the treatment of small vessel disease is evolving with innovation moving at the speed of light. Small vessels take additional time and finesse because the risk of perforation is so high. Angela Dotson, Vice President of Business Development for Access Medical Group, which has a portfolio of companies addressing complex life and limb-threatening issues, is going to be talking to us today about advancements in vascular access, oncology, women's health, and beyond. I think we're going to key off this conversation, though, with a big FDA achievement of Access Medical Group's portfolio of companies and technologies, the TalWire by Embrace Medical. So it should be a really impactful hour, and especially, John, with those patients that have below the knee disease, you know, those small vessels are pretty tough, and you have to have a lot of skill like you in saving those piggies.
Yeah, it's kind of a, well, number one, happy Saturday, Kym. I hope you had a good
Always
week.
happy Saturday.
So yeah, it's the folks that we are seeing have more and more disease that's what we call kind of distal to the knee into the foot. The vessels become smaller and smaller, as you would imagine. We have difficult time getting into those. If there's blockages, there's a lot of amazing wires out there. And I always tell folks that we're kind of talking to about training, you find a couple wires you like and get to know them, because wires are like, it's an extension of your hand basically. And there's just something about it. I can't really explain it, but you can feel the wire. That tip of that wire is in someone's toe potentially, but you're maneuvering it outside the body, and it's just kind of a surreal experience. So looking forward to talking with Dotson. I'm looking forward to hearing about the TalWire and maybe getting it in my hands sometime in the future. So should be a good show.
Yeah. You know, it'd be interesting just before we get into a little bit with her, just, you know, talking about the purpose of just overall, you know, wires. Wires are used in minimally invasive procedures to help doctors navigate the twists and turns of the vessels, right? Whether it's in the heart or whether it's in the legs. And but you got to get access to the artery, right? Before you can actually thread that wire all the way into the arteries and down the leg in order to open up those blockages. Every single device out there, like balloons where they push the plaque aside, dilate the balloons and push the plaque aside, the stents, the roto-rooting devices, they all have to thread over a wire in order to navigate the vessel. So if a wire cannot cross a blockage, they cannot treat you for the most part. And so, but still they have to get access with a wire in the first place. And with those small vessels, can you talk really quickly about how challenging that is to even get inside some of these small vessels, especially when they're so diseased, and why potentially innovation is necessary to help doctors with a little finesse?
Yeah, there's a lot to unpack in that statement and question. First of all, you have to get into a healthy-ish vessel and then put your tube or sheath in that gives you access to the rest of the arterial system. And then through that, you're often injecting contrast to light up the vessels and kind of see where the blockages are. And then through that, you're taking these wires. And traditionally, if we're talking about below the knee, we're using wires that are 0.014 inches in diameter.
Wow.
So it's like a piece of hair. Some of the smaller ones are 0.009. The tips are inches. And so they're tiny, and these wires have various coatings on them. Some are stiff, kind of a paper clip. Like I mean, some of them are very, very stiff. Some of them are very floppy. The coatings are different. And, through the years, you just kind of learn which ones work for what areas. And as I was saying, it is kind of hard to explain sometimes the feel that you get, but we call it a feedback, that tactile response to the wire. And there's some people that are literally married to a certain wire, and that's all they'll use. I learned early on in my training that that's not a really good kind of philosophy to have. You have to be able to try different stuff. And I don't know if I've spoken on this before, but I'll put a timer on our clock and say, give me 2 minutes with this wire, this device, this catheter. If it's not working, I'm going to do something else. I mean, Einstein, right, the definition of sanity is doing the same thing over and over and expecting something different. So you've got to be nimble. You've got to have a large toolbox of wires in your kit if you're going to do critical limb ischemia and complex coronary disease and complex interventional radiology disease and everything, really.
Yeah. And so I'm really excited to get into this discussion with Angela. So what do you say? For the past couple of weeks, we have not had your moment of inspiration until after the first break, but I think we need to launch it right now.
Dr. John Phillips' spectacular vascular moment of inspiration.
So I think it's only apropos to have a quote kind of around the Olympics. We all know Jesse Owens, the Berlin Olympics, 1936, I think it was, and kind of shocked the world, and Hitler for that matter. But he's got a lot of quotes, very inspirational guy, aside from having a lot of gold medals. But I was looking up a quote from him, and so I found this. And this is kind of a feel-good quote and makes you take a step back and realize we're very blessed, and we need to kind of spread those blessings. But he's quoted as saying, "Find the good. It's all around you. Find it, showcase it, and you'll start believing in it." So it's better to be good than bad, and we need to be better. We need to be better at being good, I think, as a society. So that's my moment of inspiration.
I think so. And I think along, with that is, giving people the best, the benefit of the doubt. And I think not holding others accountable for your happiness, just walking around with so much love in your heart and feeling and acceptance, I think, of all people. And especially when it comes to medicine, it's literally just making sure that you are truly practicing medicine as you do. And you talk about trying new things all the time. And there is still surprisingly this large contingency of doctors that do not continue to try and to move forward and to progress. And these patients are just miserable. So let's spread a little bit of happiness. Let's spread a little bit of good. Let's learn, let's grow, and let's laugh together. So stay tuned right here on the Heart of Innovation for more. We're going to introduce you to Angela Dotson. So stay with us.
Leg health can indicate risk.
What the heck? That was the shortest first segment I've ever had.
Was it? Well, yeah. 8 minutes, isn't it? Or no?
Yeah. What did we talk about?
Oh, I just enjoyed listening to you two. I mean, I'm so excited. I'm so excited to get into the conversation.
Angela, let me give you 2 seconds of my synopsis of how this show works, right? Kym does 90% of the work because she does. And then she doesn't, and Kym, be honest, right? Like she'll get irritated with me because she won't hear from me for a while. And then all of a sudden I'll resurface, and then I'll come up with something witty to say. And then, we're all smiling and laughing, and then we repeat the cycle, but that's just who we are.
That's just what we do. Well, we have fun.
We do. I don't think we've ever not had a good time. And Douglas is always here. Douglas knows we always have a good time.
We always do. You know me, he knows me though. Like we know each other. I have control issues. I need
She probably thought she thought I was gonna ghost her today. And so
this is the part you trust the process. It works every time. You just trust and believe, and y'all are just a perfect match together, whatever it comes from.
Oh, we could literally, he and I could just sit here and I just, especially for this show, because this is more your forte. I just was making sure that I was on the right path. I was just uncomfortable making sure that I could actually hang with y'all.
I think you did fine. And in fact, I think
All right,
you're
everyone. I love the atmosphere, but we got
bring you
about
on.
5 seconds till we air. So let's get us live in 3, 2, 1, 0.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thank you for joining us. Kym, you and I could go on and on and on and on and never get to our guests, but I think we should bring in Angela Dotson from Access Medical Ventures, right? And you've got a lot in your portfolio, but we're going to be talking to some degree these tiny little wires that we use to navigate the rivers of arteries that we try to treat and help folks keep their piggies, right?
Yeah, that's
particularly
right.
with access, right?
Yeah, yeah.
And Angela, before we get into the technology, I'm just curious, about your background and how you got into this, because you have just this unique position that you're in, working with Michael Towell. He's an interventional radiologist, I believe, out of Israel, but also he does come to the States. But he just is one of those serial entrepreneurs, serial innovators that just he's never happy with what we have until I think he can find a cure for everything and a durable solution for keeping those arteries open. I think that he's just going to keep innovating and innovating and innovating. And I'm curious, how did you hook up, and what led you to be a partner with this serial entrepreneur that just keeps innovating like this?
Yeah. So first of all, thank you, Kym, and thank you for having me on today. And I love the first part because I was just listening to you too and getting more and more excited to be able to join in this conversation. Because, when you see that somebody is so passionate about the same thing that you're passionate about, the passion flowing out. And so excited about this opportunity. So thank you for having us on today. The question. I have been in the medical device industry for well over 20 years. I stopped counting at this point. Every single aspect I can be in this space. It started out in sales, always with startup companies, bringing to market great innovation. That's a paradigm shift for the medical technology. So it's fun. I've been a part of everything, I think, from head to toe, except for specifically in the brain and heart. So I know a lot about the peripheral vascular and vascular, which is a huge passion of mine. But also the women's health and the segment. So in speaking about Dr. Michael Towell, yes, he is just an incredible physician. He's actually from the University Yale School of Medicine and based out of Israel. Our team is based out of Israel. He has brought to market medical technologies that's on the way. A lot of them are in the access portfolio for dialysis in the women's health space. Portfolio of technologies that are currently being used now. It's been game changing for. We're really excited about that. I met Dr. Towell years ago when I brought to market a technology called Claravane. The company was Vascular Insights, which has now been purchased by still in use today. Of my all-time favorite technologies, I still consider it like so I get really excited. I talk to physicians who are still using it, but the world's first non-tumescent, non-thermal efficiency. And this is because he takes current procedures that are on the market out a way of how can we make the procedure better for the patient, easier. There's a huge need for it and an offer. And, at that time and looking at venous insufficiency, so where my love for is access, because boy, oh boy, do you firsthand view of that doctors have in just gaining access to a daggone, not to mention when you start the ones that are super, super tiny below the knee.
Yes,
For the
and
things-
I wanted to, you might want to turn off your camera because your bandwidth is a little off, so you're breaking up a lot. And so I don't want any part of that to get messed up because this is so important. And I love the way you phrase, yeah, it's just so dang hard for these doctors to get access sometimes. And that's where your technology is coming in, right?
It is. And so, that was that I saw during my years of clearing with this technology, and they were larger vessels, and doctors even struggled with it, even under the use of ultrasound. And you'll hear doctors, and Dr. Phillips, you mentioning that some doctors they get stuck on do it's done. They've got a favorite. They don't want to try anything any different. But these were the challenges, up close and is that doctors would have such time doing what they had always done at hand, to the sometimes they would even have to abort couldn't get into the vessel that they were wanting to, just got so frustrated with it, and the patient table for so long that
Yeah, and it's just so difficult. You continue to break up. I think we're going to ask our producer Colin to send us to break a little bit early. Hopefully we can get this audio fixed for everybody, because what you're saying, Angela, is so important. And I want to make sure that we can get every single word out there, because I think it's not only important for the physicians and clinicians out there to hear what you have to say, but also especially the patients. So we'll be right back in just a moment right here on the Heart of Innovation. Hopefully some audio fixes. Don't go away.
3 years ago, my symptoms.
Your audio was working. Yeah. Okay.
Yes. Like I'm like where I always do my, not very well, but I can try to move. We can try to move, and I'll see if I can go into normal. Yeah, there is. So let me room and let's see if that was it. No, there's no one here. No one here but me. I have everything else off. So, and I have broadband. So, I mean, I have good Wi-Fi. My signal is strong. So I'm not exactly sure what the issue is, but we'll see if we can get it resolved.
It sounds even better already. If worse comes to worse,
Okay. Does it coming through better now?
Just keep talking, Angela.
Okay. 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 Can you hear me now? Is it much better?
Okay, everyone there, everyone can hear me?
Yep.
Yep. Keep.
Yeah.
Can you tell us about your family that lives in the house with you? I know you have kids. Just for a second,
Yeah,
so we can keep it.
Yeah, so it's just myself and my 4-year-old daughter here, and so there's nobody else here. There's nothing else that should be pulling from the internet signal. So hopefully it will resolve itself. Does it sound any better on your side?
Yeah.
Yeah.
Right now it sounds better and good. The only thing I'm still letting everyone know is that I gave the phone numbers to Kym and Angela right now to call into the studio in case it happens. So you can call in, be connected to the board. There won't be anything that is off or anything of the sort. It'll still be seamless. Right now we also have about a minute before we come back to air. Just everyone have heads up.
So Angela, if your signal starts to go and we're hearing glitching, we'll give you like, I don't know, a sign of some sort. Kym, you can do it.
Just, we'll be like, call in.
All right, let me grab my phone. Let me grab my cell phone real quick.
It sounds better already, though. I was upset. I missed what is the venous insufficiency device? Claravane? Was that what it was?
Claravane. Claravane. Yeah.
Okay.
Claravane.
That-
The
is that the one
non-tumescent, non-thermal
that the one
technology.
that
Yeah, it spins, it
spins?
rotates.
Yeah.
Yeah.
John, do you want to kind of do a quick review and lead her into maybe repeating some of the things?
So, Angela, do you want to go over what would you like us to highlight? Some of the wires or true like
Yeah.
access into the vessels themselves?
It's
or-
access into the vessel because the TalWire is an access wire.
All right, everyone. I hate to interrupt, but we have about 5 seconds till we air, so we're gonna be live in 3, 2, 1, 0.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Just in case you didn't think we were live, because some of my friends are like, why do you have to sneak away and do this radio show? Can't you just record it? Now you know we're live because we get glitches. We're not immune to the trials and tribulations of the internet. And so I think we've got things reset. And Angela, during the break, we were just kind of chatting because I missed some of it was a little bit glitchy, but let's focus on because you said the TalWire is for access into a vessel. So are we talking arteries or veins? And what kind of diameter vessels are we talking about?
Yeah, so this is a wire that can be used for any access, but mostly you're going to see it in the venous access realm. For PICC lines, midlines, small vessels, if you're doing distal distal radials, pedal cases, those cases where you have very, very small vessels that you just have a challenge getting into. As we all know, they're challenging. They're small, but also because the vein is typically very sick, and so you run into a lot of challenges of just being able to pass through an access wire to be able to even start. And a smooth access means everything with having a smooth case, as you know.
And I think it's really important that what is access? How is it gained?
Sure.
Why is it important?
Okay, so I'll just tell you my take on it since I do it every day and twice on Sunday, it seems. So access is, I mean, again, you have your artery, there are certain arteries that are close to the skin and are supported near bone. So the radial arteries for cath procedures, the femoral artery. But I mean, we can trace these arteries using ultrasound. And back in the day before this started, people would just palpate. So you put your fingers around the pulse and you take a needle and you stick it until you get a flashback. That was cool at the time, but now standard of care is you use ultrasound. So you have an ultrasound probe on top of the skin, you're rubbing it around, and you see the artery, and then you can see the needle going into the artery. And once the needle punctures the artery, because I mean, we do it in the veins too, but once it punctures, you get a flashback. And so there's pulsatile blood that's shooting out. And then you thread a wire, a small wire, typically the ones we had talked about, the 014 wires, into that artery. You take the needle out, and then over that you put just a plastic little sheath in, and then that gives you access into that vessel. There's a stopcock with a valve, and you can draw blood off, and through that valve you can insert a different wire. You can put catheters, you can put the balloons that you use, the stents, whatever. So to your point, Kym, if you can't get into the artery, you cannot do the procedure, and you have wasted a lot of resources and whatnot. And so it's really paramount that you get into it. In fact, my mentor, when I was in studying for interventional cardiology, he'd been doing interventions since the dawn of time. It seemed like he said the biggest thing that worried him was access. Like he got nervous not being able to get in. Once he got in, he was fine. And so this is the conundrum for people. You can't get in, you can't do the case.
No, but a lot can go wrong also with this access. There are a lot of struggles, the aneurysms, perforations, that kind of thing, right?
Well, right. So you have to be, depending on where you're at, which is why you want to be able to visualize the artery as best you can, typically through ultrasound. You can use the fluoroscopy in the cath lab if there's calcium and things, but you want to hit. So if you're looking at the artery, it's like a clock. You want to access it between 10 and 2, typically at like noon. You want to hit it here at noon because then you're right on top of it, because these these wires, so the wires require sheaths, and sheaths are varying sizes, and the bigger the size, because sometimes you need larger equipment to do your procedure. And with that can be complications when you remove the sheath, meaning it's not, you can have a bleeding complication, you can stick too high, too low. There's all sorts of stuff. So, I mean, getting access, doing the procedure is one part of it, but then the final part, when you take the tube out, and we have little closure devices that can help us with clotting of the blood and little stitches that we can put in. But, you know, I'm not a surgeon, and so we have to make sure that the access site is secure from what we call there's hemostasis, so not bleeding before the patient, you know, leaves the cath lab. So there's a lot of, it's not as easy as some might, you know, make it out to be.
Yeah, access. Then I'm just so glad that you went through that, because I think that that point is missed so often, the importance of access from start to finish, because it can make or break your procedure. And, you know, even with ultrasound guidance, which everybody uses ultrasound guidance for their access, you know, most of the time, the first rate pass of a wire, meaning the first time that they go in, is only around 65% success rate, meaning that 35% of the time they're having to take the wire back out, try to reposition it, try to reposition the needle, and try to go back in for access again. And, you know, every single time that you do that, you're increasing a risk for a potential perforation or, you know, damaging of the wire itself. It's not uncommon for doctors to have to open up another, what they call a micropuncture kit, to get another access wire, because they've tried so hard and it's damaged the wire, the tip of the wire, so much that it can't be used. So they'll open up another. And that also adds a lot of time to your case. It causes the physician to get frustrated, and it just causes a lot of potential complications that does not have to be there if you have a wire. Now you do, the TalWire, that can take away those challenges.
So, Kym, did you have a question?
Well, I just wondered in what way it actually, you know, from a patient standpoint, someone who's not a clinician, in what way does it take away all of those struggles that physicians have that extend and prolong the case and actually make it more risky for the patient and has the potential to give both the patient and the doctor a really bad day?
Yeah, so in regards to the TalWire, Dr. Tal, I mean, the whole reason why he invented this thing was because of the challenges that he himself has encountered time and time again with every single access. And all of the innovation was made in the tip of the wire. So he wanted to make sure that the wire was extremely safe. So he made a tip to where it's almost impossible for it to perforate the vessel, which is really important, because you know, you don't want to cause a perforation, which in return can also cause a pseudoaneurysm to occur, and, you know, other challenges. He also made the tip of the wire articulating. So basically it self-corrects itself. So when you go in, if you bump into, you know, calcium, or you're hitting against the wall, it just self-corrects itself to the point to where it's going to find the true lumen. So, and this happens on the very, you know, so what it enables is that almost 80 the clinical trials, in over 88% of the time, the first pass, even for physicians that had no experience whatsoever doing a distal access or a distal radial access, in 88% of the time, the doctor was able to pass the TalWire on the very first pass, making complications, you know, a lot of those complications removed.
And when you talk about radial access, you mean when they go in through the arms. So you're saying that even in coronary cases, so that's a market for you, for
Yes.
those doctors that are performing the heart catheterizations.
Yes, yes. So pedal cases, we've had doctors, interventional neurology, that have used this wire. We've had it used in, you know, pedal cases, the vascular surgeons, interventional cardiologists, basically all those areas where small vessels are a challenge to be able to get into. And you know, you don't want to have the complications of potentially perforating the vessel, or having the vessel, you keep poking that vessel to where it's just going to shut down, right? It's going to close off. And so in those cases, the TalWire has been used already in our limited market launch, and the doctors absolutely loved it. So we're really excited to have it available to physicians now.
So is this a micropuncture system or
Yeah. So the wire comes in an 018 or an 021 wire. 40 centimeter, 60 centimeter. We're working on a longer wire as well. Basically it's going to be dictated by the physicians who use this of what the wire ultimately at the end, becomes available. But yeah, I mean, it's a standalone wire. It's not a part of any particular micropuncture kit right now. It's a standalone wire. But it is the wire for those challenging cases, and doctors typically know which cases are going to be the ones that are challenging to them. You've done it enough to know that this is going to be, oh man, I hope I don't have trouble getting into. So if that's the case, pull your TalWire and then just be done with it.
It's a wire then that you're not using to do interventions over. It is just to get access into the
right.
artery.
It's just to get your access, and then you can switch out and be able to do your interventions with any of your crossing wires or, any of those other wires that's on the market. And there's wonderful technologies that's on the market to be able to accomplish these things. But again, if you can't gain access to the vessel to be able to get it started, it's pointless.
Right. So just to clarify for our listeners, we talk about micropuncture. The tip of you see that opening in my pen, that is about the size of some of the sheaths that we put in. So traditionally you could use a needle that was smaller than that, but big to it's a puncture needle. We have morphed into using what are called micropuncture systems, where the needle itself is so tiny that it fits, for most part, I believe, like an 018 wire, so 0.018 inches. So it's a pretty small wire, and that creates less trauma to the vessel. So the smaller the initial hole you put in, the less complication risks you have, and doing it under ultrasound is different. But at the end of the day, we have all morphed into using, or at least most of us have morphed into using these micropuncture, because you don't, I mean, if you miss with where you want to be in the position of the artery, you can take it out, hold pressure for a minute, and reinsert, as opposed to using a big, one of these bigger needles. And that's what we all use. And so I would imagine, as you're saying, Angela, you would take your standard micropuncture kit, but then use the TalWire in lieu of the one that's given to you.
Yeah,
right?
yeah, exactly. Because and I mean, this is the feedback I hear all the time. Even from physicians who are operating in larger vessels, they're like, I hate the wire that comes with my introducer kit. It's a terrible wire. Like they have a really hard time gaining access. And so if you have a case where it's a challenging case and the access is challenged, especially in the small vessels, then the TalWire is going to solve those problems for you, because it has the articulating tip. Because it really doesn't matter. Listen, you can have ultrasound, you can see the vessel, you can see the lumen, you can try to navigate all you want, but you still pose the issue of perforating the vessel and, having to keep going in and going in and going in until you help your wire find the lumen. The TalWire, the doctor does not have to help the wire find the lumen. The wire finds the lumen. And that's a big deal, because everybody's skill level, no matter what doctors want to say, everybody's skill level is different when it comes to access. And so what Dr. Tal wanted to do is he wanted to make even the least skilled physician, like the new doctors that are coming out, that are, still in residency, even that are learning this skill, that they are able to access a small vessel very easily with this wire without risk of perforation.
And that's really good, because so many patients end up as guinea pigs for these residents, in the
Exactly.
for the first time. So you want to give them the best tool they can.
You want to give them the best tool.
Fail. Yes.
And why would you not? Like, that's my thing is if you can have a technology, I don't care what technology it is, if you can have a technology that can make your procedure safer, it can make it better, it can help make your outcomes better for the patient overall, why would you not? period.
We're going to find out
Exactly.
more here on the Heart of Innovation. Don't go anywhere. This is AM 1220 KDOW. Stay tuned on the Heart of Innovation. Everybody's clear.
We got to let him in
Man.
once. We got to let him in once.
I know. We were just waiting for you, Colin.
What are you talking about? Y'all were having a great time.
We were
So we've had some questions from folks, and I think we
yeah.
kind of need to explain to them what sizes we're talking about here.
Yeah,
'cause
like
these
even
arteries
what
are-
size, what size are the arteries? And then, I mean, we're talking, they're pretty small, but I mean, you have the SFA and you have the CF, those are, and iliacs, those are pretty big, vessels. But then, as you get further down the leg, like they're much smaller. But what size are we talking about? And then when you talk about the 014, are we talking, the size of a typical hair strand? Or are we talking a regular string? I mean, we are talking pretty thin. I think that's what Douglas is trying to.
Do you want me to show wire?
When you said that, Dr. Phillips, that was my first thought, because I don't think most of us as patients have an idea how big they really are.
Sure.
You showed us,
Yeah.
you showed us your pen, and my first thought was, is my vessel, because I've never really seen a vessel in person, so I don't really understand, how big my
So
vessel
what I would say
actually
is your like a typical pinky. I've got smallish hands, but like this pinky is about a centimeter in length. And so a centimeter is 10 millimeters. So we're talking about like an iliac artery is about this size. Okay.
Okay.
So that's the size. So everything gets incrementally, and we'll talk about this on air, but it gets incrementally
That's
smaller.
why I put that on there, because that was my first thought. Nobody's
Douglas,
ever
I'm here for
actually
you. I'm here for you, baby. We'll explain it for you.
The camaraderie is strong. We got about 5 seconds till we air, and we're going to be live in 3, 2, 1, 0.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Fantastic conversation about access and the trials and tribulations thereof. So as such, I think it's important to kind of talk to the audience about what size vessels we're talking about. So if you grab a standard pen is probably around a centimeter in kind of diameter. Your pinky is often about that size. So these arteries, an iliac artery, so that's kind of like the first branch off the aorta, which is the biggest artery. A normal aorta should be less than 3 centimeters in diameter. And so then they branch at a little bit below the belly button and then continue to branch into smaller and smaller, kind of like a tree, big oak tree with the trunk and the branches as they ascend. And so sometimes we are accessing arteries that are 2 millimeters in diameter way into the foot. And that can be tricky because the needle itself, which is very small, can actually take up the size of that artery. The other day we were trying to, the gentleman that we spoke of last week who almost committed suicide because of his pain, I had to get into the bottom of his foot in a vessel down there. And so we were able to get into it. But again, you're talking tiny, tiny vessels in the heart. Okay. So typically a heart artery is about 2.5, 3 millimeters, 3.5 millimeters in diameter. So a third of a centimeter. So it's small. These are small. Okay. And I think Angela has, for those that are watching on YouTube, has
Yes, I have the wire. I'm going to hold this up. I don't know if you can see it, but you can see how little.
Yeah. Wow.
It's extremely small.
Yeah, tiny.
And so this here. So the tip is, let me pull this up here. The very floppy tip. So whenever you're going into the vessel, you want something that tip is not going to go into your vein or your artery and poke into the side of it and perforate it through. So it's very important that you have safety that's in there, because you want to have it, you want the tip of your wire to be able to be sturdy enough to be able to pass through, but you want it to be safe enough to where it's not going to cause a perforation. And the tip is just very thin. It's very small. I'll hold this up there again. But that's
Wow.
the size that you're looking at.
Yeah, it's very thin. I mean, it literally, I mean, I mean, it's almost like as thin of as a sewing needle.
It
Very
really
small.
is. It really is. I mean, like in all honesty, if you could see the tip of this, if you're somebody that is familiar with thread and sewing, there's actually fabric thread out there that's about, you know, the same diameter of this right here. It's very small. And so all of the innovation with this is in the tip. And it's, you go in, you know, one of the challenges is, I'm going to flip this around to the other side. So this other side, if you hear that, do you hear, like, I don't know if you can hear it or see it, but you see whenever I hit the back of this, like there's not much give. There's nearly no give. It's very stiff. Now, most stiff, but they still have the perforation. If you change it around here, even if I hold this tip very close, it's bouncing off. Like you can't get it.
Can you shape the tip?
This tip you can't shape. You can't shape it. It's very flexible. It gets more stiff as you get up into the shaft, which gives it, you know, what you need to be able to pass it through. So if you have a little bit of, you know, calcium or something there, that it'll push it through. But the tip of this is not going to perforate. It was designed exactly for that. It's designed to articulate so that it'll find the true lumen of
Can you
what
send
you're
me some
trying
of
to
these
get.
wires? How do I get some? I want to try this. How do I
Yeah,
get this?
I'm going to send you. I'm going to
You
send you some. So,
you have to come see us in Ohio? Where are you at?
yeah, we'll get you some wires out. But this thing it's truly amazing. And what I can tell you is it's just the fact. I don't care how skilled you are, even under ultrasound, getting access to these small vessels is a daggone challenge. And it would just be so much easier if doctors together would be like, yeah, you know what? Like, it'd be great if we could figure out a way to be able to get into these daggone vessels, you know, the first time, without having to just sit there and play around with a wire, and it get everybody frustrated and put the patient at more risk for having a perforated vessel, or a vessel that has spasmed down to the point to where you can't even now do the procedure that they're there to begin with. So, you know, if we can all just wrap our heads around and just recognize that, you know, we're going to be off to a much better start of being able to practice better medicine for everybody and having better patient outcomes for the patient.
I love that. I'm curious from John's perspective, because it's interesting. I don't see you get excited about things like this that much. And so I'm curious, just when you're listening to this, what role do you think, how much do you think something like this actually would help in your practice?
So honestly, for me, and again, like, this is what I do. But I do this all the time. So for me, I don't have a lot of issues getting into these arteries, because just I've made enough mistakes that I know how to finagle it. I will say that some of these micropuncture wires, because they are, and I don't know how much a micropuncture kit costs and what the wires are made of. I typically use one from Cook, but there's other ones. But sometimes I will put a bend on the wire so I can spin it and get it to where I want it to go. But in doing so, you fray the braid, and then it'll get stuck. So imagine you've passed the needle into the artery, you're trying to finagle the wire, it'll fray, and then it gets stuck and you have to pull it out and get another wire and such. But I think, to Angela's point and your point, Kym, there's a wider range of folks that are just starting out.
Yeah.
And so I think the opportunity is much greater in individuals who may not be used to using micropuncture, may not be used to, I mean, we all like to talk a good game, but not everybody uses ultrasound and things of that nature. I also think there's a very big role in this when something is, quote, done blindly. So, for example, in the ICU, we had conversations about using micropuncture in our ICU when someone's really sick and they're trying to get access into an artery or vein very quickly. There's concerns about perforation with these micropuncture kits because you are shoving a wire in there and they will go places, the wire goes sometimes places you don't want it to go, out a small little branch. And then you can have a perforation if you don't watch it go, because if you don't have access to fluoroscopy or radiation, guidance. And so I think there's clearly a market for it. These devices don't come on the market for no reason. So there's obviously a market for it.
It's just adoption's always, a struggle, but I think the real market is really that the newer, doctors that are coming on, especially because even you said, gosh, you've made your mistakes. Now you're really good at it. But, I wouldn't want to be one of those patients and have that mistake made on me. So if there's a device out there that would prevent those mistakes,
right.
I would be like, yes, please.
I'll tell you, the advent of the micropuncture, I know we're coming up on break here, but the advent of the micropuncture has really helped patients avoid major complication. We talk about stick location or major bleeding, but again, there is always an opportunity to innovate and make the case more efficient and safer for the patient. We at the end of the day, you want to do what's right for the patient in the safest way possible.
Everyone's clear.
Mic drop. That was a mic drop, people.
Yeah, you didn't say anything, Colin. I was going to say something, but
I usually leave it up to you. But Kym, is my watch right? How much time do we have left?
We only have 4 minutes in the last one. I know that Douglas, we have a few questions, but Douglas, we covered that in the beginning and of exactly how it works. So I didn't want to go on air and talk about that again. It's basically you have, and maybe John, right after we get done, you could, or going in to the next segment, you could just talk about again, hey, we've been talking about access. They use what's called an introducer. Here's how they, go in with the ultrasound.
Everyone, hate to interrupt. We have about 5 seconds till we air. And we're going to be live in 3, 2, 1, 0.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
As always, time flies when you're having fun. We only have a few minutes left. So just again, recapping here, the device that we're talking about is a singular wire that allows you to advance, get into after you put a little needle into the artery, advance that wire through safely, and then you take the needle out. Now you have a wire in the artery, and then we just put a little tube in, a small tube, and then through that small tube we put a bigger wire and then a bigger tube, and then you're off to the races trying to help people. So it's a very simple concept, but it can be very complicated. I think that's the way I look at it.
Yeah, that's you said that perfectly. And going back to like something that you said in the last segment, about your skill set obviously is above a lot of physicians who are just starting out, because with access, it's all about practice. I mean, doing it over and over and over and over and again. So kind of the tips and tricks of being able to access a stubborn vessel or a small vessel that's, just really challenging. But, to speak on, a lot of times whenever you're having to manipulate the wire, change the articulation yourself in the current wires that's out there, you do, if you didn't have to do that, then that's a big deal, because you don't want the risks associated with what comes along with manipulating, the current wires that's on the market. And I think that was one of the things that, Dr. Tao saw himself, was he was tired of having to change the integrity of the wires that he was using just to try to gain access, right? Because you always want to make sure that you're keeping the integrity of the wire intact for as much as the procedure as you can. And so the TalWire does that. And so that was one of the things that we're really excited about with it. And I'm really excited to get this in your hands, and I can't wait to hear your feedback on what you think about it. Would love to hear that. So
Yeah, I
And I'm
definitely
thinking,
we'll talk offline.
and John, from your perspective, we still have so many doctors that literally will amputate, without even attempting to open up those smaller vessels below the knee because they do think that there is too much risk. Do you think that this is something that might help inspire more doctors to treat below the knee? It might reduce or mitigate at least some of the risk with it, or do you think that's not going to have an impact? Or maybe that's just the beginning.
I think that when you have the opportunity with technology to take a case that maybe somebody would have balked at, but then say, all right, I think I can try this. That is an added benefit for the patient. Real quickly, I was referred a patient who had multiple attempted procedures, and they wanted to do a high AKA, major amputation above the knee on this woman. And so I said, tell you what, I'll give it a shot and help. And I'm not a miracle worker. I'm not saying that, but I opened it up because I know what I can do. When you don't know what you can do, you don't do it, right? I mean, the eye sees what the mind knows. And like, that's where you have to think and use the technology out there. And if you don't know what's out there, you don't know what's out there. So it's fantastic. This is called the heart of innovation. We're innovating and trying to help people get better and treat people and do what's right.
Okay, we're clear. That second mic drop, John, you're just full of
I'm sorry,
inspiration
guys.
today.
I'm
My
done. That's it for
goodness.
me. Kim, that is it for me. I'm out of here.
I know. I
So
was like, yeah, I could interrupt that wonderful moment that you had. It was so clean. I was like, yeah, no, I'm leaving that alone.
I hate to sound like a broken record, but it is unconscionable in 2024 that this woman was going to get a major amputation
Mhm.
when it took me literally 2 minutes to get across this blockage. And once you get across the blockage, you can figure out a way to fix it.
Mhm.
And it was nothing special that I did, but I don't know how, and maybe, and so again, like, let's walk it back a little bit. There are people that aren't used to, this is being recorded, right?
Yes.
Okay. So if you have, if your tools consist of needles, wires, balloons, stents, you think differently when your tools consist of that plus a scalpel. Okay. So I think, and I've seen this before, when folks go to potentially a surgeon, that the default can be a transition to an open procedure or bypass or, God forbid, amputation. I don't have that luxury. And so, and I've talked to colleagues about this, and maybe I'll be crucified for saying this, but when I don't have the luxury of pivoting to opening somebody up and doing surgery, we have to kind of think a little bit differently, and therefore get alternative access, just try different things. And it's not the end all be all. Surgery has a role. We've talked about that both in people that have claudication as well as critical limb ischemia, but you just think differently. And so if this wire allows people to think differently about micropuncture using ultrasound, then maybe they'll take the step further and try working a little bit harder on a blockage of some sort that maybe they would have done bypass on. My soapbox and editorialization, my opinion only, but that's what I think.
I know, opening up that Pandora's box here, especially
Mhm.
because that's where a surgeon will say, that's why you don't go to an interventional cardiologist. That's why you don't go for an interventional radiologist. You need to go to a surgeon that knows when to say when with minimally invasive, tools, and goes to open and has that in their toolbox. Now, that being said, I mean, I think, how do we evolve medicine and continue to practice medicine if you keep resting upon your laurels and falling have something to fall back upon. We still don't have a cure for PAD or the advanced stage critical limb ischemia. And until we do, until we have the holy grail, we got to keep evolving. We got to keep practicing medicine and finding new ways to do that.
Right.
Yeah.
And we're not going to cure it because you have to put, I mean, it's like a tiger in a cage. You open up that cage door, that tiger's getting out. So you got to keep the tiger in the cage. And you do that by being proactive instead of reactive. You take care of yourself. You don't smoke. You watch your blood sugar. You exercise, and then you exercise, and then you exercise. But we've talked about this too. Now we live in a society where we outsource discipline and responsibility. And so it's an uphill battle. But I will say that there are a lot of great vascular surgeons out there, and the vast majority of them want to do what's right for their patients.
Yep, I
And I
agree.
even know in our practice, we have a very collaborative effort. And listen, if I need a surgeon, I call one. And if they need some remote vessel opened in the foot, they call me. I mean, like, that's the way we work, and that's the way you should work. And that's
Yep.
what patients need to know. They need to know that, like the Leg Saver hotline, they need to know that there are folks out there that can help them. Again, it drives me nuts to think that this woman who was 83, she was going to get a major amputation. Yep. Leg Saver hotline. What area code is that, by the way?
415, San Francisco Bay Area.
Excellent. Anyway, sorry, you've just struck a nerve here, but I'm just going to say it drives me nuts to think that this woman would have had a major amputation at 83, which is tantamount to a death sentence for her. So I don't know how long the stents will last, but she's never going to lose her leg as long as I'm involved in her care. I can guarantee you that.
No, and I think that that's amazing because you got to have great teamwork in a hospital. There can't be animosity. I just had the discussion this week. Ooh, Kim on her soapbox.
Mm-hmm.
With a
You go,
large
girl.
university hospital. But I'm right there with you. University hospital, and the patient was actually referred to the vascular surgery department. And this patient called the Leg Saver hotline and said, I actually don't want to see a vascular surgeon. Are there other options? And I said, well, you were referred over there. If you do want to go to another person, there is an interventional radiologist that in the same university that has advanced skills. I'm happy to make that referral. This is what the patient asked for. We had nothing to do with it. Patient preference. We honor what the patient wants. That is what's right. So I ended up calling up the interventional radiologist and I said, here's the deal. This person was referred over there. They have an appointment scheduled for August 8th, but this patient does not want to go there. They want to go to a different practice. I mentioned you. She said she wanted to go to you. And he said, oh my God, you are going to cause so much fire within this system. They are going to blow. And so we had to figure out a way in which the patient ultimately would almost get off their radar for vascular surgery. And she canceled the appointment. She told them, you know what, I've just decided to go elsewhere. Do not bother following up with me. And we were able to maneuver around, and this other doctor was able to go into the system once she was cleared somehow from that vascular surgery department. And then he re-inputted her back into the system, but under interventional radiology.
That's so ridiculous. It should not be that way. It should not be that way for any patient.
And it's not like in our health system at Ohio Health, it doesn't function that way. It's so a lot of times somebody comes in to our hospital and they have a toe wound. It depends on who's on call from the ER or the hospitalist that admits them, and they'll put a consult in for vascular surgery. A lot of times we then get consulted from interventional cardiology because they have, wounds that or something that's amendable to an endovascular approach. I want to be clear here. There are a lot of fantastic vascular surgeons out there. There are a lot of vascular surgeons that work collaboratively. There are a lot of vascular surgeons that do great endo work. So just because you're going to a vascular surgeon doesn't mean you're going to get surgery. And that doesn't mean you're going to get a major amputation either. It's important. At the end of the day, you have to have collaboration. And I will say this, since we have started, we now have 16 hospitals within Ohio Health. And as part of the Vascular Institute that I run, we have started looking at our mortalities and amputations in our critical limb patients, and what we are going to come up with kind of a best practice algorithm, if you want, or flow sheet or whatever. And one of them is going to be no patient under our care, or one that I want, is going to be that no patient under our care that's an inpatient or outpatient for that matter is going to get a major amputation unless there is discussion with both a surgeon and an interventionalist that this patient has no revascularization option, whether it be surgical or endo, because no one should get a primary amputation if there's hope. Now, some people come in and there is no hope. And I know that, and I hate seeing it. It happens. But anybody that has hope is going to get a chance, or they're going to have two people say, yes, yes, nothing can be done, go for it. And that's where you get collaboration.
Yep. And I think that that could set the standard, you know, and I do want to go back. I mean, what's really amazing is to see this new contingency of vascular surgeons that are so open to all of the new techniques and literally are all about endovascular first and exhausting all methods. And you have Vincent Rowe at UCLA, you have Dr. Anita Dubois over at Mass General, Dr. Michael Sia over at UT Southwest, Dr.
Can't stand
Christopher
that guy.
South.
I'm just kidding out of the mic.
I know. He's
love
such
him.
a good guy. He's so humble too.
Well, so like you asked me for my schedule for next week. I'm out a couple of days because I'm attending a course called HELP at University of UPenn. But we are doing, through the sponsorship of Boston Scientific, a fellows course for advanced limb preservation. And so there's cadavers, and we're talking, there's about 5 of us, I think, on faculty. And the faculty consists of, let's see, I'm looking at 1, 2.
Dr. Genovese, is Dr. Genovese there? Dr.
Yeah,
she's amazing.
Yeah. So there's 3 vascular surgeons. I'm the lone interventional cardiologist, and then there's an interventional radiologist, and then Dr. Michael Jaff, who's the CMO of Boston's Peripheral. So, I mean, there's 3 vascular surgeons there, but all these folks are committed to revasc, whatever it takes. I mean, so again, a lot of positive things from vascular surgeons, and there's positive things from IC, IR, negative things from IR, IC, and vascular surgery.
I mean, I have to admit, when we're working with patients overall, we are not considering necessarily, you know, what is your practice? We're looking at the person's presentation of disease, where they're located, geography, what their insurance is, and some other factors just personally with that patient and their preference, you know, in helping them to find a doctor that's near them that will become the best partner in care. And it crosses, you know, practices. But I will say that if there is an interventional radiologist or interventional cardiologist, I will make sure that they do have a partner in crime who is a surgeon, and there is a strong bond between those departments, and that they do have that. And even with the doctor at that large university hospital I mentioned, he does have one particular surgeon over there at the department that he works very, very closely with. And they do share things back and forth between the two.
Indeed. Looks like, Douglas, your hand is up.
Yeah, Douglas.
This has been utterly fascinating, and it's kind of blown my mind being able to learn. I've learned so much today. It's incredible. But for you, Angela, with where you started and where you are now, how hard is it to get in the door with this technology in some places? And we hear Dr. Phillips talk about this and the importance of it, but how hard has it been to get into the door and make those changes?
So we just have launched this commercially in the US. We did our limited market launch with, you know, physicians that obviously, you know, we've worked with throughout the years, just because we wanted their feedback initially. But in my experience, I can tell you, in my 20 years of experience from my early days of being in sales and bringing to market new technologies, it's difficult. And it's not so much the physicians typically get it. They want new and innovative technology. They're the ones that are, you know, having to treat these patients, and they want to do what's right for their patients. The issue is with the hospital facilities. It has, just in the past 10 years, it used to be if a doctor wanted a technology, they wanted to try it, they would just tell the representative, whoever had the technology, I have a case this day, come in, right? Bring it in, I'll try it. The rep would come in, they'd try it, and then if the doctor wanted it, okay, great. The doctor said pretty much it. The doctor truly drove what technologies they used on their patients. Now those days are gone. And this is my soapbox. So
You go,
this
girl.
is my soapbox because now the doctors, they have to fight tooth and nail just to do what is clinically in the best interest of their patient. They have to fight the hospitals tooth and nail. And it is not right. They have to go through what's called a value analysis committee. If they want a technology, even to try it, most doctors, even if they want to try this wire on a technology, they have to go to the value analysis committee, put in a request, and then that request is sent before this whole panel of people. A lot of times, physicians who won't ever even use the technology, don't have any clue what it's even designed for, are going to be the ones that are making a decision whether or not, let's just say it's Dr. Phillips here, is granted permission to bring it into the hospital to use it. It's a whole process that I kid you not, can take anywhere from 6 months to 1 year from the time that the physician says, this is a new technology I want to try it. It can take that long just to get approval to bring a technology in for a doctor to try it. So it's not so much with the physicians, okay? It is with the hospital administration that has put so much red tape on these physicians, and it's absolutely ridiculous. It should not be that way. And I don't even know where to begin to make changes to it, but it's just not right. So I know that's a little soapboxy and a little bit on it, but for patients, I think it's very important to understand that it's not always the result of their physician because they don't want to use these technologies. They're up against a really difficult force that they have to deal with, and they spend a lot of time fighting and being an advocate for their own selves just to be able to have what they need to have the best outcome possible for their patient.
Wow.
Quick
Angie,
question.
sure.
Couldn't part of that be because of liability?
It's not, I'll put my 2 cents in, then Angie can chime in. But I would say that since COVID, it really changed, at least in Ohio Health, how we have access to new technology. I would honestly, before that, I mean, you could tell the waters were shifting, the wind was shifting a little bit, but somebody like Angie could come to me and say, hey, I got some wires, boom, I'll take them. And it's free of charge. So here's the deal. This is a business. Medicine is a business. And so you have to have some type of return on the investment. You have to show that there's added benefit to whatever it is that you want to bring in, and it doesn't cost an exorbitant amount of money. So before COVID, she'd give me, this is the way it would work. Somebody would come to me, hey, we got this. I'm like, all right, give us a couple of them free of charge. We'll try them out, see if we like them. If we like them, we'll put them on the shelf. Now it's, okay, yeah, we're going to start the ball rolling for a new piece of equipment. Oh, and by the way, if you've never been into our health system, you have to go through the VAC committee, and you also have to get plugged in. You get blah, blah, blah. And then you can bring it in, and then you give me some samples free. And then we decide, okay, well, what are we going to take away? Like, you don't need 5 of these wires. So now a wire's a little bit different. Like, I don't have any, this is not going to be hard for us to get this wire in. But so, for example, for this conference, I have to give a talk, and I have to talk about some specialty balloons that we have that have little blades on them and various other things. We have about 8 specialty balloons in my inventory. And that's probably all we're going to have or all we're going to need. Anytime you add something new, you've got to take something away, and it can't cost more than what you're kind of swapping it with. And so we play these games with industry. Yeah, you got something new, but is it going to be, it's got to be cheaper than what I have now. And you're going to have to give me some for free. And but again, that's just the way it is. And that is the landscape that you Angie, have to deal with in your as an industry.
Yep. Yeah, you're right on so many levels with that. You know, from our standpoint of doing this so many years, we see it not so much. I mean, obviously, you have to prove that your technology is safe, right? No doctor is going to use your technology unless they know that it's safe and it's safe for the
Right.
patient. Same thing with
Right.
the hospital. So that's the
Sure.
liability aspect of it is not. I don't see it as being the huge driving force behind this. Rather, from my side of it, what I have seen is it's mostly the cost issue of it. Because whenever you are so most new innovation comes out from startup companies, okay? They're not the big companies like a Medtronic or a Boston Scientific. Most of those companies will buy new and emerging technologies from a startup company, okay? But they don't buy it until it's been on the market and they see that it's being used and there's value in being able to add it to their portfolio. So it makes it very difficult for the startup company because most of these hospitals have contracts with these large companies like the Medtronics and the Boston Scientifics, which enable them to be able to get the technologies that they're using, whether it's a wire, whether it's a stent, whether it's whatever, at a much better cost, okay, than what I can come in as just a startup company with very limited resources other than just my new wire. I can't come in and give them what a Medtronic company. So we have to really navigate that VAC committee. And it's difficult, let me tell you. I mean, this is where it's very important for companies, startup companies, to have people that are very well versed in how to build the relationships with the physicians like like Dr. Phillips here, and also know how to navigate through the VAC committee and what they require, because it's a process and it's not for the faint of heart. I can tell you that much.
No, I can tell you too. I've been trying to develop a catheter for 3 years now, and it's gone are the days when you could come to a company with a design or a concept, and then they would build it out for you, and you'd get some royalties or something. I mean, you know this, Angie. You have to go. You got to develop the catheter, and you got to see that it works, and then you got to find somebody that's going to buy it, and like you said, it's not for the faint of heart, and the hurdles get higher and higher, and more people, never finish the race, frankly.
They do. It's really, I did not understand to its full capacity what exactly was involved in bringing a technology to market until I started working with Dr. Tao and truly understanding like what a long road, how difficult it is. And patients definitely don't understand this. For a new innovation to actually come to market to the point to where it can be used on a patient, what has to go into that? The number of brilliant technology ideas that never come to fruition just because of the red tape through the FDA process, trying to get it to commercialization, it is so extremely difficult. So when a new innovation does come to market, I think this is, again, on my soapbox, I think it's also why I get so frustrated at the physicians who don't want anything about new innovation. They want to continue doing things exactly how they've always done it before, because it's not like new innovation is coming out like every single day. It may seem like it is, but guys, it's really not. And so as a physician, I implore every physician that if there's a new technology that's coming out in your field, take the time to look at it. Take the time to really address its unique abilities to see how it can fit into your portfolio of treatment options for your patient. It may not take the place of what you are doing 100% of the time, but it may make the difference, a huge, significant difference for that one patient that anything else that you were using, you were not going to be able to provide that patient with an optimal outcome. So I implore every physician to take a look at it.
I do have one more question. Dr. Phillips, maybe this is maybe for you. So as she was showing us that needle, is that part, how do you make the decision between going through the wrist or the groin? Is the vessel different sizes? What makes that where's that choice come from?
So I will tell you that in the heart world, so to do a heart catheterization, so, you know, my wrist is here, I can snake it up to my heart, right? That gives us access to, so all roads lead to Rome, basically. Well, if you can get into one artery, you can get into all of them for the most part. We started doing radial access because the types of equipment that we need and the size of the equipment has gotten so small that you can do it through a pretty small sheath or tube. And radial access has been shown to reduce complications in patients who are having a heart attack or undergoing what we call PCI stenting. And it's because of the lack of access site complications. The access site complication, meaning going into the growing, there is risk of bleeding. There's risk of putting the tube in too high and having a bleed into the belly. There's risk of putting the tube in too low and creating a connection with the vein. There's some, you know, unfortunately, we live in America. Folks can be a little bit rotund. So there's a fair amount of soft tissue that you have to get through to get into that artery, as opposed to most people's wrists is nothing. And it's just, it's evolved where I would, you know, I think every attempt should be made to do an intervention through the wrist in the heart. There is opportunity through longer tubes and things to do some of the procedures that we do through the wrist. But again, we're hindered because sometimes you need a larger tube to get the stents in that you need, the bigger the stents in the legs. And so that is sometimes a rate limiting step. There is actually a mortality benefit, so less mortalities in people who have heart interventions through the wrist than through the growing. And again, it's because of the access site complications. But for somebody who does femoral, so femoral, that's the artery in the growing, for someone who does a ton of femoral access, you know, my complication rate's very low, but folks that don't do it, it can be high. And again, this wire is an opportunity to help mitigate that risk with use of the micropuncture system. I don't know, did that answer your question?
Yes, sir. And
As
again,
a patient, I just had that done to open up an artery in the heart, and oh my God, what a difference!
Well, yeah, right. So
what
patients
a
love it.
difference in recovery.
Patients love it. We typically went through the right wrist. There's a little air pillow wristband that we put on afterwards. Yep. They're sitting up. They're eating with their left hand. They go home the same day. Now you can go home the same day anyway with the heart, with the growing, but there is a probably 10 to 15% risk of radial artery occlusion, meaning the artery can thrombose. Thankfully, you have an arch. So the other artery on the side toward the pinky is called the ulnar artery that communicates in the palm. So if that artery closes, very few people are symptomatic, but some people can get symptomatic from it. And again, if it closes, you can't open it. But the surgeons will use that radial artery as a conduit or a bypass as well. So there's redundancy. But yeah, most patients, in fact, I think there's only a handful that I know that would rather not have it through the wrist if possible.
And I think it would be really good to probably.
What just happened here? Are you driving, Kimberly?
I am driving. I have to go to a funeral for a friend that ended up with an aortic dissection, because, and this is the second one I've heard about, that the doctor didn't give a patient after they had their procedure. You know, they go home and they weren't given any anticoagulant therapy, not told to take aspirin, nothing. And so blood clot, and we were doing so great, and I was helping to advocate for it. It was great. And nope, they didn't give her anything, and she died of a blood clot. So I'm going to the funeral actually right now for that. It's crazy. But, you know, so with all of this information, you know, patients may want to go to their doctor and say, hey, do you have the TalWire? And that would be music to the ears of Angie, right? But the reality is a doctor is more likely to get pissed off if the patient goes there and says, hey, do you have this? I want you to use it. It's the only thing. Versus coming in with a question, which I think would be possibly appropriate. Hey, I was watching this YouTube video or this show, The Heart of Innovation, and I learned that getting access to an artery can be very, very risky, and it can make or break
the case. What do you do as a physician to mitigate that risk and increase the success rate of the case, and especially the access to get the case even started? What do you think about something like that? Because, going and asking, hey, do you have the TalWire? I don't want to go with you because you don't have the TalWire.
Yeah, I mean, like that's like I know nothing about cars, and me going to my mechanic and saying, "Hey, I want you to put this brake." I'm making up things, and forgive me for those of you that know things about cars, but I always tell people, "Do you trust your mechanic?" Yes. Okay, then they will do what's right for you. In the same vein, I ask the patient, "Do you trust me?" Okay, then I will do what's right for you. I started when I give lectures. I put up, why should you listen to me as a proceduralist? Well, this is the number of cases that I've done. These are my outcomes. Here, this is the validity of me speaking. So you can ask the docs. I mean, like I would not have a problem with the patient doing that. I would have a problem with the patient saying, "I want you to use X, Y, and Z on me."
Yeah,
I'd say,
exactly.
Yeah.
just
And I can
read your
tell you
language.
that's not what we would want, and nor should it be. I mean, most patients never know what type of device a doctor is using. That's not their thing. But as a patient, and I can say this from on a patient side, but also, as somebody that has been a part of the medical device industry for over 20 years, what, I always advocate for is that the patient just to be really informed of their doctor and what their thought process is and how their clinical practice is, and being able to feel comfortable enough to engage in those type of conversations about learning about the procedure, learning about how, they do the procedure. It's okay to ask, exactly, what does this procedure entail for me? Like, are there any challenges, or anything like that? But, patients should be their own advocate to a certain degree, but you have to be able to have trust in your physician that's going to be doing this procedure to know that they are going to be doing the best.
And a lot of patients, they don't know enough. They don't know what to ask. But so, for example, the lady that we were able to help who was going to get the major amputation, how did this work? Her granddaughter worked in a surgical OR or a cath lab in another hospital, and some of the industry reps from companies were there, and they kind of saw what was going on, and then they told her to reach out to me, and that's how this happened. As long as you have an advocate, and this is why we talk about getting second opinion, third opinions, I think it makes sense. And so this is why we do this show, and this is why Kym does what she does. It's just to raise awareness to this disease that frankly sucks, right? And so
It
And I
does.
think that, we use the term trust very loosely, because I get calls from patients all the time that, oh, well, I trust my doctor. Well, why do you trust? Well, because he works at this large hospital and because he has a degree, I like him. Well, that's not the trust that we're talking about, because for me, I would trust you, Dr. Phillips, because I know that you are using advanced tools and techniques, and I know your outcomes. I know that you use different approaches. If you can't get through a blockage coming down from the top, I know that you are going to go up through the bottom, what we call retrograde or pedal access, and you're going to try coming up and tackling that blockage from the bottom. And so these are the things that we tell our patients, that it's great to trust a doctor, but you need to know what goes into that trust, why you should trust that doctor, what goes into the skill set that you should require of a doctor. And so it's not necessarily, do you have the TalWire? Not necessarily, do you have the laser? Not necessarily, do you have, some other, the new biodegradable stent from Abbott. But we had a patient that messaged me today saying, hey, I want to go to this particular university hospital. And actually, it's the only, I think there are 2 university hospitals that actually refuse all roto-rooting devices, all atherectomy devices. They literally will not use them at all. And that's not something that, for me, would gain my trust in a department. If you're going to completely eliminate something that does have evidence to prove that it can have benefit when used as indicated in medically appropriate cases. So I do caution patients when it comes to trust.
Right. One of the talks that I have to give is about atherectomy, and why why use atherectomy? And atherectomy's gotten a bad rep because a lot of reasons, but there's a role for it, frankly. And so, yeah, I mean, you've got to, you have to ask the questions and be open-minded. And at the end of the day, what really gets me with patients, and this is where I still trip up a little bit, it's kind of like, okay, if I was your dad or your grandpa, what would you recommend? And that seals the deal for me. And that's when I become, okay, black and white, here we go. So
Are you is that term vetting? You kind of vet you learn, you go and see like how many procedures of this have they done and what their success rate is?
Yeah, I mean, I think if you ask a physician and like, how successful are you, and they kind of skirt around it, then I don't know that that's like the right person for you. Maybe, I don't know. That's just my opinion.
And Angela, that excitement you have, where do you see we going from here? I'm sure you know things are coming down the line, and how exciting is that to see the new technology that we're learning every day?
Oh, I'm incredibly excited about it. You know, for me, I am in a very unique position, especially working with Dr. Michael Tao, because he loves, this is his passion. Okay, he still works 1 day a week, but he still innovates. Like I'm telling you, I tell the guy all the time, I'm like, I don't even think you sleep. I think you just dream of new innovation and just constantly doing it.
Mhm.
But it's really exciting for patients to know that, you know, you do have physicians out there like the Dr. Michael Taos of the world, and, you know, even sounds like you, Dr. Phillips, you know, with things that, you know, you've got in your head that are constantly working hard to make things better for you, the patient, who really care about you, the patient. I know from our side of it, you know, the TalWire, you know, we got FDA approval. It's now in the market now. That builds on 7 previous technologies that Dr. Tao has brought to the market that's currently being used out there today. We have another technology that we're working on getting FDA approved with a brand new chemo port for cancer patients, which is just going to be phenomenal. Super excited about that. We've got, you know,
Yeah, I was
innovation that,
wondering. I
yeah.
was wondering if that could, because that seems really interesting for us, even for the show. That, but I don't know if that's enough for an entire show for us to talk about. Like, you know, I was like, gosh, should we have you on next week? And because we didn't even get to even Empress Medical and the innovation happening for fibroids that you're
Yeah,
working on.
I mean, we've got, yeah, the chemo port is super exciting, and I am so thrilled. That is going to be absolutely revolutionary, and is going to be changing the way that chemo ports are placed for forever. So we're really excited about that. Empress, with the uterine fibroid, we will have the first technology that is going to be not only effective at treating uterine fibroids, but also preserving fertility for women, which is huge because there's nothing on the market that truly preserves fertility for these women who are being treated for uterine fibroids. It's a huge deal. And it doesn't stop there. We've got things in the pipeline for the Dallas fistula. We're going to be addressing that market soon as well with a just game-changing technology that's coming down the pike. And the list goes on. I mean, there's just so many things, and it's all really exciting things because these are technologies that I can tell you they're all about the patient, and they are going to be complete game changers for patients. Super exciting things.
Yeah, that's awesome. We'll need to have you back. Do you think a full hour show on the port, or
Yeah.
is that enough? I mean, I could see if there's maybe we can get an oncologist to come on with you.
Yeah, I think so. I mean, there's a lot to talk about that, you know, there hasn't been any true innovation in the chemo port space in over 30 years, which is just mind-boggling to me. So, you know, the type of innovation that we are bringing to market is pretty crazy. The chemo ports will now be able to be placed in the oncologist's office by the oncologist or a nurse practitioner. So patients are no longer going to have to wait to get on a surgery schedule, even for the physicians, even for interventional radiologists and vascular surgeons who fear, oh my goodness, well, y'all are taking this away from me. You're still going to have some interventional radiologists and vascular surgeons who are still going to place ports. And even for those physicians, what it's going to allow for them is if the procedure has to continue to be done in the hospital, they can move that procedure off of their schedule, free them up for a bigger procedure that really needs their attention. That's a more, bigger focus than just a port placement, and allow the nurse to be able to do it. This is huge. This is a complete game changer for cancer patients and hospitals and oncology clinics alike. It's a win-win-win for everybody. So, revolutionary is definitely the word of the day whenever it comes to Portal is the company, FlexiPort is the technology, and so it's coming. We're in our last bit of getting this submitted to the FDA, and we will be ready to go.
That's exciting.
Yeah.
That would be really cool to have that technology. But I'm wondering at this point, because you are pre-FDA, are you still testing it? Is it still the studies, or is it just completely kind of, at this point where it's just a waiting game, so no one's doing it anywhere?
We're finished with whatever clinical studies that we had to do. It's a 510K. So just so patients, know there's really, two routes down the FDA. If you have to do a full like clinical trial, that can take years to be able to do that. Or you can just get a 510K, which is based off of something else that's already in the market that's very similar. In this case, it's already based off of a chemo port that's in the market. So it's an easier pathway through FDA than what the normal thing is. So we're not having to do a ton of the clinical studies. We're already finished with everything that we needed to do, and we will be ready to submit here to the FDA for the final, pathway to 510K in about 3 to 4 months, and expect commercialization in about 8 months.
Angie, can you help me get my catheter to fruition?
Oh, wow.
We can talk offline.
That, actually.
Let's talk offline. Thank you.
Yeah.
So,
I love it.
So just a lot of great innovation.
So we'll definitely would love to have you back before, as soon as you get that clearance.
Yeah.
And so we can actually, talk about that further. We'll put a little blip up of what you just talked about, separately. Maybe our producer, Josh, wouldn't mind cutting that clip out where you talk about this new port. That would be awesome. So we can put it up as a separate clip. I think it'd be exciting. But also, so next week, I wanted to ask Dr. Phillips if we could do, because I think that this is really interesting as well. And what I love about Dr. Phillips, he's always thinking outside the box. And, not just depending upon just traditional. Well, you're not, you kind of shocked me in getting involved with this organization, Game Day, that has so many alternative treatment options for patients. And I'd like to put you on the spot, about Game Day next Saturday.
Okay. Next Saturday. Yeah. Okay. Hey, listen, I'm happy to answer any questions. The reason why I got involved in this is because I'm sick and tired of, and I keep referring to this, and maybe I've got to come up with a new catchphrase, but being reactive instead of proactive with patients. You come and see me with PAD and CAD, the horse is out of the barn. I mean, we can get you better and we can help you, but let's stop you from getting there, right? Mm-hmm. Let's close that door.
Yep. And so I think that would be an interesting discussion. And I've been watching some of your explanations on different things. So I thought we could go through some of the different things that they offer, why they're important, and we can get, I think, some different content.
I'm happy to help.
I went watching a couple of it too, Dr. Phillips. And are you going to spread that out, or is it just where you are, or is it in the hope?
Oh yeah, no. So this is it's a franchise. It started in Carlsbad, California. There's 100 plus. It started franchising in 2021 and it kind of exploded a little bit 2023, 2022, 2023. We were the first one to open in Ohio, but there's two other ownership groups in Columbus even. So it's this is why I was a little late today, because I was doing an event with a Lifetime Fitness locally, and we were showing them some of the things that we offer. And my spiel is, it's not a spiel, but I always tell the people that I interact with, I want to help you be the best version of you. And I don't want you to come see me at 2 a.m. when you're having a heart attack. I want you to see me at 2
come to
p.m.
Texas. You need to come to Texas.
I think there's a lot. There's several in Austin. I know that for sure. I imagine there's quite a few in Texas.
Yeah, but they don't take insurance, so it's all private pay.
Right. So, I mean, that's the other thing too. Like, we are cash-based business, but we offer concierge medicine, and you have direct access. You as a patient has direct access to me as a cardiologist. Most of them don't have a medical director that's also involved in the ownership. So that's a little bit different and makes us unique.
So I
that I think will be really
fun. Can I have
fun.
one more question?
For me?
For Angela, I tend to ask this to a lot of our doctors. Think about back in the beginning, what brought you into this? Was there a specific reason why you got off into this? Was there something in life that made you interested in this, and now here you are?
Yeah, great question. Thank you for that. So, yes, it's personal for me. I live, and I still currently live. I've been born and raised in the rural part of Southwest Virginia, and so I know all of the challenges that come along with healthcare in rural parts of the country. And I was very, very close to my family growing up. My uncles were like my brothers. My aunts were more like my sister. And my uncle, one of my uncles, had a tragic accident whenever he was 17 years old. I was 7 at the time, and he became a quadriplegic. And so I spent a fair amount of time in my young years in and out of UVA Hospital, Woodrow Wilson, with my family, because they were the primary caregivers of him. And living here in the rural parts of Southwest Virginia, my family had to learn a lot about healthcare and how to provide care to him, because the fact of the matter is there was a lot of physicians back here and a lot of nurses that had no idea how to care for a quadriplegic. And so a lot of that was cast on to my grandma and grandpa, who, it was his mom and dad, and my mom and his other uncles. And then obviously, I got to see that too. And that sparked in me at a very early age that I knew I wanted to be a part of the medical system and finding ways to be able to just help people. And I was fortunate enough that was what drove my career of wanting to get into medicine. But I was the first generation college person in my family, the first one to go to college. And so I didn't go to medical school. There's many times now looking back in my career, I kind of wish that I did, but I believe that everybody's path, you're put on your path for a reason. And so I was put on this path to be involved in helping to bring new and innovative technology to market. And as such, I have been a part of some really great conversations, really great opportunities of just seeing some technologies that have truly been game changers. And so that's what drives my passion whenever I look at these technologies. Even though a wire may seem like it's simple, right? It's just an access wire. When you've been a part of procedures and you have to see a patient be told, I'm sorry, but we just weren't able to gain access today, so you're going to have to send you home and try another day. And you see the look of, defeat on their face because they've spent their whole entire day arranged to come thinking that they were going to get a treatment that was going to help them, and now they're being sent home. That matters. An access wire then becomes something that could have made a huge impact to a patient. So for me, every technology is personal because it's impacting somebody's family. That's somebody's mother, father, brother, sister, daughter, son that's on that table. And we every single one of us has a duty to put forth the effort in making sure that we can help each other and we can give each other a better quality of life in whatever capacity that is. So that's what drives me every day.
Yeah, that's beautiful. Absolutely beautiful. And strike a chord just with that access point. I've seen those cases where the patient is in, you're only doing procedures when a patient is in debilitating pain. They're being awakened at night by Charlie horses and they can't sleep. They have to pace. I mean, to get even a little trickle of additional blood flow to relieve at least some of the pain so they can sleep. And when they go in for these procedures, they really have hope and that there's going to be some relief. They see a light at the end of the tunnel. And when a doctor just can't even get started after having that really, really is demoralizing, for these patients. I mean, they lose hope so quickly. They can spiral right into a depression because sometimes you can't get them in. Dr. Phillips, till 2 weeks later at times.
Yeah. I mean,
Yep.
all of these things, and we haven't even talked about, I know we're talking about, the TalWire as it relates to some of these procedures with, amputations and things like that. But, there's a whole nother side of this, for pediatrics that we don't even talk about that, we foresee the TalWire just being a game changer because these little babies, their little vessels are so tiny and it's really hard to get into when you look at these little NICU babies. And that's personal for me too. I have two daughters. My first daughter, unfortunately, passed away 29 hours after birth. She was a NICU baby. And as a mom, I had to endure conversations of how difficult it was because she was very sick, of them being able to gain access and having to draw blood from her time and time again. And one of the nurses that we work closely with is a NICU nurse. And, they really advocate for, getting femoral access on these NICU babies to try to find larger vessels so that they can be able to gain access. And a TalWire is going to be instrumental in being able to help these physicians gain access to these tiny little humans and be able to save their lives. So everything that we do matters, just because it might not affect us directly. We might not have any experience in that particular field, doesn't mean that it's irrelevant. And I think that's something that we always need to keep at the forefront of our mind is that, everything that we do has an impact that's of us combined. And it's certainly so in medicine.
Right.
Well said.
Well, I appreciate you so much
Yes, thank
for
you.
being here. It really means the world to us. We hope, we can have you back and we can schedule you out and just plan on letting us know the date so we can also talk about that chemo port. I think John would agree that would be a really interesting and very popular topic for so many people because it is going to be such a game changer to be able to have the port access implemented in the clinic versus having to wait, for the OR to open up for a procedure to do that. So that's really exciting. Love everything that you're doing.
Thank you. Thank you. Yeah, I look forward to that, definitely as we get closer and get our approval. And then the same thing for Empress with Orbital, with the uterine fibroid. That's going to be another just wonderful, wonderful technology that, as a woman myself that suffers from uterine fibroids, I am like so excited about this technology. I'm not having any more kids. So that part, for me, but I know what it was like for me during the years that I was still in childbearing years and suffering from uterine fibroids and, having to wait until, I got finished having kids before I chose to address uterine fibroids because I did not want to pose any additional risk to my fertility. So these things are real. All of these things are real. And I can't say thank you enough to you all for putting the spotlight on all of these crucial things to patients and being a true advocate. There needs to be so many more people like you. So just thank you for everything that you all do. It really makes a difference. And I appreciate you all bringing me in and just letting me be a small part of it today.
Thank you so much.
Thank you so
Appreciate
much.
it.
thank you, Dr. John, for spending so much time. Oh my goodness. It was really powerful.
Well, thank you guys. I appreciate it. It's good conversation. It's always fun to chat too and learn about new things. So have a great weekend, everybody.
Awesome. Everyone have a great weekend.
Cheers.
Bye.